Yeah, because you're gonna record there, you're not gonna record on, right? Okay, so yeah, I think this is.
Hi guys, welcome back. Probably last but not one before we finish the endocrine module. So we have urinary incontinence today and then BPH. The syllabus says otherwise, but it's more or less just a way we want to deliver it so that you get the foundational concepts before you get into the BPH. You can see your slides on Brightspace. Any housekeeping things before we get started? Any questions from the last lectures? We met briefly on Friday for those students who missed the session. I have posted some questions on Brightspace on osteoporosis folder for you to review it. And if you have any problem solving them, come and see me. But other than that, it's very straightforward lectures. Okay. All right, moving forward, we are talking about urinary incontinence. Again, the way you have to test yourself is able to answer this objective by the end of this class. For the interest of time, I'm not going to go through all of them, but that's kind of like the whole idea of you to test yourself as you go through this objectives.
Background information as it relates to urinary incontinence.
All right. Okay, so that was pre-recorded. Sorry about that. Moving forward with urinary incontinence, it's defined as an involuntary leakage of urine, especially the lower urinary tract symptoms can occur such as urgency, frequency, and nocturia. So it's not something which is irrelevant or you haven't heard about it, but that's kind of like the big picture of what we think of urinary incontinence. And then we're going to go dive into understanding the etiology, but for the most part, that's what we define as an involuntary leakage of your urine. There's 51% prevalence among 51% of the prevalence among women in the United States. Peak occurs around menopause. It's associated with anxiety, depression, decreased quality of life, ulcers, fractures, chronic UI is one of the common reasons for institutionalization, which may increase the risk of mortality. Right. So if UI doesn't get treated, it's gonna, for the most part, it's infectious. It can more or less move around in the body, and that may lead to other complications. So earlier than better if it gets treated. And most importantly, Dr. Grisby would talk more about understanding the underlying etiology than just UI. UI basically is a manifestation of something which is going behind the scenes. So identifying the main cause or the main etiology which can lead to UI is very, very paramount in understanding for the doctors to treat this problem. Coming to some science aspect of what does urinary incontinence all about. So here we have a picture of your urinary bladder. I asked one of your students to get me a balloon today so that we could just do in real time something about what I really wanted to. Just the same color. All right, so that's basically your bladder. And we have a ureter, which is basically a spinster, right? So we're talking about different types of urinary incontinence going forward. So we are basically talking about the pathophysiology. So we have this bladder. So the bladder has two types of muscles. One is muscles which are under the control of M3, which is muscarinic receptors. And on the opposite side, we have muscles under the control of sympathetic nervous system, which is basically your beta-adrenergic receptors, okay? So muscarinic and adrenergic, which is basically your acetylcholine or norepinephrine, are controlling the bladder to hold the urine for contraction and relaxation. So let me ask you a quick question. If you want to relieve yourself, what should really happen in principle? So we have like a gateway down here. So that's like your spinster. So what should the spinster do? It should contract or it should relax? It should relax. And what should contract there? On the top, the pressure should. So this is all smooth muscles. It's basically are under the control of norepinephrine and acetylcholine. So the pressure should go on top and this should relax so that you can relieve yourself well. Are we all on the same page? That is what happens even with urinary incontinence. but that is involuntary. You are not controlling, but it's basically happening without you controlling it. So there is some reason that a stressor, which is not in your control, it applies unwanted pressure or unwanted pressure over here, or it opens this sphincter, it doesn't tighten up enough, so you have some drops of urine leaking out. Makes sense? So that's kind of like the big picture. We're gonna go into detail about talking all of it. Things for you to remember on this slide is muscarinic receptors, which are responsible for contraction, beta adrenergic receptors, which are responsible for relaxation. So there's a contraction component and there is a relaxation component. Let me ask you a question here. The problem is that there is an unwanted pressure applied over here. How can we help the patient with a UI? Can we produce more contraction or produce less contraction? What could be the pharmacology here? Do we want to relax his bladder or contract his bladder more? Relax his bladder. So for you to relax his bladder, which drugs can we use? If muscarinic receptors contract the bladder, what can be the drugs which can oppose the contraction? Muscarinic antagonist. Muscarinic antagonist will reverse the contraction to relaxation. So now there is no more pressure applied. Make sense? Let's see the opposite thing. Beta adrenergic receptors. Do we want to contract or do we want to relax the bladder when we have UI? We're talking only with the context of UI problem. So these are pre-recorded slides which we borrowed from our previous instructor. So sometimes you may have audios on those slides, so just ignore, or if you want to hear, you can always hear it out. But the idea is beta adrenergic receptors, relaxation or contraction. It's already causing relaxation. We want to help the patient more. We use beta-3 agonists. We're not talking beta-1. Beta-1 is in your heart. Beta-2 is in your one heart and two lungs. Beta-2 is in your lungs. Where is beta-3 present? It's around your urinary bladder, the detrusor muscles. Okay, so we're going to relax that. So that's kind of like the third strategy, the second strategy of helping the patients. Then coming down to your urethra, or we basically call it as sphincter, this is under the control, basically, of against alpha adrenergic receptors. So what is alpha-1 responsible for? Just normally alpha-1. Alpha-1 comes to your mind on smooth muscles. Vasoconstriction, okay? So alpha-1 agonist will constrict the urethra, the sphincter. That's what happens here. So if we want to really help the patient with urinary incontinence again, what are we using? Are we using antagonist or agonist? We want to contract his sphincter. If we relax it, he's going to still leak more urine out. Alpha-1 agonist, okay? That could be a third class of drugs which we can use potentially. So that's kind of like the pharmacology behind how and why each receptors are important, because most of the drugs out there are going to target these receptors to help the patient with UI problem. All right, if you understood that, you basically got through the whole UI lecture, what I would be covering. Let's go slide by slide now. So we have this filling and storage phase, and we have bladder emptying phase. As we discussed initially, when we are filling or storing the bladder with urine, what we really want to happen, we want this to be contracted, this to be more relaxed, so the bladders can fill the urine. So that's kind of like the urine sphincter should maintain the adequate tone to resist the passage of urine, because there will be always pressure. But if this is completely well locked, the air will not pass through. If it is not locked, the air will pass through. Basically, your urine can have a potential to be leaked out. When you come to a bladder emptying phase, which is the reversal of the filling phase, what are we expecting in emptying phase now? We want the sphincter to go loose, right? And we should have more pressure on your detrusor. So we have a detrusor muscle where we have more pressure, and the sphincter should go loose so a person can relieve himself. Are we all clear? We use a term called as normal micturition. It's basically urination, okay? That's kind of like the term which has been used across your textbooks. We're talking about receptors. We're talking about muscarinic receptors. Muscarinic receptors are of three types. M1, M2, and M3. Before we go into M1, M2, M3, which neurotransmitter binds to a muscarinic receptor? Acetylcholine? Yes. Acetylcholine is the neurotransmitter which is endogenously produced in the body. It binds to this muscarinic receptors, M1, M2, and M3. More importantly, we are concerned with M3 receptors because that is what is present in your bladder. And if you have acetylcholine acting on M3 receptors, it will cause contraction. That is what we really need in cases for a person to for a normal micturition process. So M1 receptors, it's present in your GI for gastric acid secretions. M2 is present in your bladder and heart. Prominently, M3 are the ones which are basically on your bladder. So we will target both M2 and M3, but for the most part, it should be M3 receptor selective for a drug to basically not have effects. If, for example, my drug is non-selective and it hits M2 and M3, what are we expecting? Again, if my drug is non-selective and it hits both M2 and M3, because we have bladder here and we have bladder here, I get synergistic effect, or I get off-target side effects. We get side effects because you can see that sitting out there, the heart, it goes and hits on your heart. And what are we expecting acetylcholine to do your heart? Bradycardia, it decreases your heart rate. Okay, so any drugs which are going to act on M2 receptors are going to decrease the heart rate. Okay, you are understanding the M3 pharmacology right now. We're talking about different receptors and how they can. Other things to think about with acetylcholine, our homeostasis class, I always told when we talk about acetylcholine, it is a rest and digest system. And we basically are requiring, when we are resting and digesting, we're requiring secretions. So whenever acetylcholine is on board, your GI secretions, your lacrimal secretions, your nasal secretions, everything is high. So if you use an antagonist, why are we using an antagonist now? Because we are talking about M3 receptors causing contraction. If you contract this, the urine will leak out. We want to relax it. So we use M3 antagonist over here. We are going to reverse these contractions. Okay. So when we are reversing these contractions, what are we doing to the secretions as well? Which is caused by acetylcholine. We're decreasing the secretions. A person can have dry mouth. Okay. A person can have dryness of the secretions in his body, the lacrimal secretions or nasal secretion. That is not going to be a problem if you have a selective drug which acts on your M3 receptors, because for some reason, it has an ability to just go and target the site required for its effect instead of hitting other places and causing other side effects. Okay, just so that you understand. M4 receptors is in the striatum and frontal cortex area. Let me ask you a quick question. If you are hitting M4 receptors and M1 receptors, what are we doing? We're talking about brain over here. What are we going to do if you have drugs hitting your brain? If we are going to, M1 is responsible for cognitive function, we're talking about antagonist of M1, right? Because that is what we intend for UI. So if you're going to increase cognitive function by stimulating M1, we decrease M1 receptor function, we decrease, just put that. You decrease the cognitive function. So your person may have some kind of impairment or in coordination with his cognitive function and day-to-day activities. Moving on, we're talking about the etiologies and the types of UI. So we have 4 different types, which has been broadly categorized. One is stress-induced urinary incontinence, urge-induced urinary incontinence. Mixed is basically stress plus urge. 1 + 2 = 3, which is your mixed. And then we have an overflow incontinence. Okay, the diagram speaks volumes about what it really is all about. Stress is basically problem in your sphincter. Your sphincter is not locking the bladder properly, so there is always going to be leakage out. With your urge incontinence, there is so much of pressure on your bladder that the sphincter is unable to control, so we have some leakage. So there is too much of activity going on in your detrusor muscles. Okay, so urge-induced incontinence. Mixed is basically both of them, as I told you. It can be a problem in the sphincter or the detrusor muscles of your bladder. And overflow is basically, for some reason, the body is under diuretics or some other drugs, which causes more of urine storing. So these muscles are not working properly. Whenever the bladder fills enough, the detrusor should contract. So for some reason, the detrusor is not working properly, or it's not, the contractions are not happening as appropriate as required. So it can cause overflow. Whenever there is overflow, there will be small leakage of urine, and that can cause overflow incontinence. Are we clear? We'll go one by one. Moving with your stress-induced incontinence, I put something on yellow highlight just so that you understand what we're talking about. Urethral muscle closure is inadequate. That's kind of like the main cause. We have really good definition here: incontinence upon exertion. Usually it's episodic, low volume leakage. Pathophysiology, as I told you, it has inadequate urethral closure forces, and urethral sphincter are unable to resist expulsive forces generated from physical activity. So this is all like making sense as you read through. I don't want to read through all of this, but just to give you a brief idea about what is it all about. Okay, things for you to consider are the risk factors. Who are the people who are under risk? Pregnancy, childbirth. Whenever there is high force applied on the detrusor and the urinary sphincter, they can be one of the risk factors for people to have stress-induced incontinence. Males, basically, it's rare, but with kind of surgical procedures around the urinary bladder, that can also lead to stress-induced urinary incontinence. Causative agents. Let's think about this for a bit. Always remember, as you see this diagram, start writing the receptors, because your receptors function is going to be a play here. The reason I'm asking you is drugs over here, they are the reasons to cause urinary incontinence. If you don't know what alpha agonist is doing, you cannot decipher what antagonist will do. When I say alpha antagonist, what is it doing? We have this sphincter tone, which is under the control of which drug or which receptor? Alpha 1. Again, everyone, please look at the board. We have alpha 1 here, we have M3 here, we have beta 3 here. M3, beta 3, alpha 1. Alpha 1 is equal to vasoconstriction. Yes or no? If we oppose alpha 1, what are we causing? Vasodilation. So what's happening to this? It's dilating. Do we need a dilation or a constriction at this time? For a urinary incontinence, we need a constriction. But if you're using a drug called alpha antagonist, it's going to make it worse. So it can cause urinary incontinence as well. One of the causative agents. We have ACE inhibitors. One of the things which you may have heard about is what? The biggest drawback or side effect of ACE inhibitors. Dry cough. So the cough induced. So when there's so much of pressure put on the urinary bladder, it can induce some kind of urinary incontinence that comes under the category of stress-induced urinary incontinence. Are we clear? Urge incontinence. And always remember, when there is urge, it's basically your detrusor muscle contracts inappropriately. It's more than when it is required to contract. So it's contracting, it will cause leaking. Very, very common. So the detrusor muscle contracts inappropriately, it leads to urgency. Pathophysiological, maybe neurogenic or myogenic, or it can be a combination. Things for you to watch out, maybe aging, BPH, bladder outlet obstructions. Some of the neurological diseases can also cause for it. I have written some information for you to go through for each of the neurological condition, how that may interfere with the urinary incontinence. First one would be like Parkinson's disease. Parkinson's disease is a disease which we didn't get through the CNS module yet, right? Okay, we'll talk more over there. But the idea behind Parkinson's is involuntary movement. It's under the control of basal ganglia. Basal ganglia is the part of the brain which is important for controlling the movement. For some reason, Parkinson's disease, this is affected. This involuntary movement will also cause involuntary movement of your bladder muscles, and that may interfere with urinary incontinence. So the problem is not UI, as I told you. There is an underlying problem. A person have Parkinson's disease that may relate to having a urinary incontinence. So everything has to happen in synchrony for your body to function at normally, otherwise it can lead to that. MS is called multiple sclerosis. It's basically a disease of myelin sheath. The myelin sheath is kind of, what is the function of a myelin sheath of a neuron? propagation of the message from one neuron to another. If that is gone away, what happens to the propagation? Propagation is impaired. If propagation is impaired, the message required for your brain to say when to relieve and not to relieve is impaired. That may impair the way a person can void or not void. It's not no longer under his control. So that may be one of the factors which people think can lead to urge-induced incontinence. And then we have something called as damage to the brain regions, which actually control your bladder. We have prefrontal cortex and brainstem. And again, that can impact your voluntary bladder functionality. So what's the big problem here? With urge-induced incontinence, we have a problem with your detrusor muscle contracting inappropriately. So when it applies more pressure, the sphincter is not able to hold it, the urine gets leaked out. Moving to causative agents, diuretics. What's the diuretics doing here? What is the function of diuretics? What does it do? All right, so it's going to cause increase in the urination, so that will overwhelm the bladder, and that may lead to incontinence. People who have diuretics can end up having urinary incontinence. Alcohol. One of the functions of alcohol is inhibition of ADH. What is ADH? Antidiuretic hormone. So we are inhibiting a diuretic hormone. What are we doing? We're causing diuresis. Come back to this. That can also lead to urge-induced incontinence. Choline esterase inhibitors, P1 class. What is choline esterase inhibitors doing? Write down ACHE space I. We call this as acetylcholine esterase inhibitors. Acetylcholine can be broken down by enzyme called as cholinesterase. Norepinephrine can be broken down by two enzymes. What were the two enzymes? MAO and COMT. Remember? So norepinephrine can be broken down by MAO and COMT. Acetylcholine can be broken down by cholinesterase. Okay. So now we're talking about cholinesterase inhibitors. So what are cholinesterase inhibitors just doing? They are inhibiting cholinesterase. Are you able to correlate? I have to draw a picture for you. We don't have anything here. There is no draw option. No draw option here.
Create a text box.
Yeah.
I don't think you have a text box on it. There you go.
What is acetylcholinesterase really doing? Can anyone help me? The acetylcholinesterase breaks down. So let's talk about a scenario where we have acetylcholinesterase inhibitors. So what will happen automatically to this? We have more acetylcholine in the synaptic space, yes or no? This option will go away because it's not going to break down acetylcholine. Are we all on the same page? Okay, so there is more acetylcholine in the synaptic space. This acetylcholine can go and act on your receptors. What are the receptors present on your bladder? M3 receptors, right? This M3 receptors will further cause what? Increased contraction of your. So it will cause contraction of your detrusor to cause UI. Are you guys getting this? Okay, so we're going back to this slide again. And we talk about cholinesterase inhibitors. Now you understand how that is happening. It causes increased acetylcholine. In the synaptic cells, that acetylcholine can go and act on acetylcholine receptors like M1, M2, and M3. Right now, we are focused on M3. That M3 receptor activation can cause increased activation of detrusor muscles to lead more action on detrusor muscle. What is this urge-induced incontinence? There is more happening on the detrusor, which can cause leakage of the urine. Are we all on the same page? Overflow incontinence, Daljit.
Someone doing the work.
All right, moving to overflow. Here, detrusor muscle contracts weakly. We want it to contract not inappropriately, not weakly. We want it to contract optimally. So everything is happening synchronously, which applies weakly. What happens now? More pressure is not good. Less pressure is not good. Just the right pressure so that a person voids properly. When it's not applying pressure, what's happening to the urine? Where is it staying? It's staying back in the bladder. And when the bladder is only so much, it can only hold so much. So whenever you walk or you put some pressure on it, this is automatically going to leak out. The sphincter can only hold so much. Get it? So that's kind of like called as overflow incontinence. And again, this is urethral overactivity or bladder underactivity. There can be a couple of reasons to it. Bladder underactivity or urethral overactivity. That can both lead to overflow incontinence. Again, with males, we have benign prostatic hypertrophy or prostate cancer as one of the underlying reasons. Causative agents, alpha agonist. What is alpha agonist doing? Vasoconstriction of your sphincter. So what's happening with vasoconstriction of your sphincter? Go back again. What is happening? You're tightening this bolt too much. So what's happening to the urine? It's not coming out, it's staying back. But your body can only hold so much. How much tighten you can make, it will automatically have some way to out. It cannot just hold it forever. Otherwise, this will blast. But this is not like balloon. We have smooth muscle, so it can lead to other complications. Anticholinergics. Let's talk about it. Cholinergics causes contraction. What does anticholinergics cause? Relaxation. So relaxation of the bladder leads to what? Relaxation of the bladder. It's holding more urine, which we don't want in first place. So that can also be one of the factors. We have calcium channel blockers, opioids, and antipsychotics. I'm not going to go much into them, but for the most part, I wanted you to focus only with relevance with cholinergics and sympathomimetics for this class. As I told you, mixed incontinence is a combination of stress and urge. With urge incontinence, there is bladder overactivity. With stress incontinence, there is urethral underactivity. Either of them is not good. That can lead to mixed incontinence. We have a diagram here. We have too much activity or too little tone. And again, diagnosis is very often challenging. And then we have functional incontinence, which is kind of like something not relevant with your anatomical dysfunction. It is more of a problem which is common in patients' day-to-day activity. It's mostly expected to people in elderly or people who have mobility deficits or cognitive impairment. So when a patient falls and fractures their hip and requires hip surgery, after the surgery, patient is immobile and will not be able to access toilet in a reasonable time frame and can experience incontinence. So we basically call that under the category of functional incontinence. Okay. Drugs which can cause that, maybe sedative hypnotics. Okay, a person on sedative hypnotic is expected to do what? If I give a person a sedative or hypnotic, what are we trying to do? What are this class of drugs responsible? I know we don't even go through the CNS module, but do you know what a sedative hypnotic is expected to do? To make you sleep. Why we have to make a person sleep? It's not anesthesia. So what are the reasons we think we want to calm the patient down? Anxiety, okay? Any of those hyperactivity, symptoms where you go back to sedative hypnotics to calm the person down, the whole idea. So when you put a person to calm down, it will impact his memory, his cognition. These are all the side effects, and that can finally lead to incontinence, because if a person is not cognitively functioning, he doesn't know when to pee, when not to pee, and that can be a incontinence problem, how much to hold, how much not to hold. So as I told you again, and Dr. Grisby will touch on that, we gotta find out the underlying problem before getting to start treating the UI. Oh, came to knowledge check. Okay, perfect. Let's go one by one. What is the primary cause of stress-induced urinary incontinence? We're talking about stress. Think about it. Where is the problem happening? Is it the bladder? Is it the sphincter? It's the sphincter. So which is the closest one? Do we have overactive detrusor muscle, weakness or inadequate urethral closure, bladder outlet obstruction, or increased diuretic use? For the most part, it should be B. Which of the following agents can worsen urge incontinence? We're talking about urge incontinence, so we're talking about the detrusor muscle not working in an appropriate fashion. So which are the drugs which can worsen or increase the risk? Diuretics and alcohol. Okay, why do we think that? We talked about this a bit. Diuretics are going to cause increased urination, so the detrusor muscle is not functioning properly, and alcohol is inhibiting antidiuretic hormone that can cause increase in the urge incontinence. What is the common risk factor for overflow incontinence? Which category is overflow incontinence? The third category. Okay, so what do you think can lead to overflow incontinence? What is it?
BPH.
The BPH, benign prostatic hypertrophy. So we talk about this in the next class, but for the most part, this is one of the problems, which is hindering your ability to urinate properly. It's like a muscle mass or tissue which is overgrowing. It is non-cancerous, so it is impeding the ability for a person to void normally. So that can kind of influence the overflow incontinence. Let's move on. Mixed incontinence. What should come to your mind? I'm not spending time there. Mixed incontinence is stress and urge. What mechanism contributes to urge incontinence? So we're talking about urge. Stress is basically your sphincter. Urge is basically your detrusor muscle. Okay. So what mechanism contributes to urge? Detrusor muscle doesn't contract appropriately. Which conditions are most likely associated with urge incontinence? Parkinson's disease and stroke. All right. Think about that and then test yourself again by the end of class today and see how you're doing. Moving on, this is just one slide.
Yeah, that's mine. This one. Oh, you use that. It's not. Let's see. Can get this work. That one. That's okay. I know that's this one. Oh, so when we think about reversal etiology of urinary incontinence, so before, and like what we do with a lot of things, you want to make sure that you understand what the etiology is. So we don't want to go into, I'm loud. We don't want to go into treating all of this different stuff. We don't want to go into treating the UI if all this different stuff is going on. So when you do your patient workup, when you're interviewing your patient, like you guys have done in lab, you want to think about other causes. So delirium. So if the patient's experiencing delirium, the patient's not in their right mind, right? There's other things going on. So the patient's not in full control of their bladder. It's the same process kind of as what Dr. Muhammad said, where you have that neurological portion. If there's an infection, so if there's an infection or a UTI, the urethra of the bladder is irritated, right? There's lower back pain, there's pain upon urination, pain anywhere. They may not be able to hold because there's pain. So they're going to have urinary incontinence. Same thing with vaginitis, urethritis, there's inflammation in either the urethra or the vaginal area. Pharmacologic agents, so the causative agents that Dr. Muhammad showed you, all of those agents that are contributing to that, you want to decrease those doses or change those agents to see if the urinary incontinence is better after that. Psychiatric disorder similar to the delirium, endocrine or excessive urine output. So when we think endocrine, we think about diabetes. One of the hallmark symptoms of a patient experiencing diabetes is increased what? Increased urination and increased thirst. So you have patients that's either taking in more liquid because of the fact that they have diabetes, or increased urination because the body is trying to get rid of the sugar via the urinary area. So diabetes control is going to control the urinary incontinence. Think about restricted mobility. If they can't get to the restroom, then they're not going to be able to hold it only but for so long. And stool impaction, thinking that, okay, if they already have a blockage somewhere, it's causing symptoms already in the lower area of the body, which can lead to urinary incontinence. The back of it.
We do 10 more minutes and then we'll break. Is that okay? All right, so moving to your medicinal chemistry, we're talking about antimuscarinics, the first potential treatment for UI. Why do we think it is going to help? Because of antimuscarinics. What is antimuscarinics expected to do? To stop muscarinic drugs to work, or muscarinic effects. So it's basically your M3 receptors around the bladder, which is under the control of acetylcholine, antimuscarinics, because of what? It's an antagonist. What is antagonist expected to have? More affinity, right? It has more affinity to bind to the receptor. It blocks any of the agonists to bind to it. If any agonist doesn't bind, there is no more inappropriate contraction. So the idea behind antimuscarinics is ability to block those M3 receptors that would lead to decrease in the way that the detrusor muscle contracts. We have the pharmacophore for a antimuscarinic. We have X, basically the halogen. It's nispotent and it's ester. We have R1 and R2, basically your alkyl groups. So we have carbons or heterocyclic. That can be your R1 or R2. The rings can be identical or it can be different. Different rings basically have more potencies, and rings can be fused in the case of solifenacin. So I have basically taken all this information, 1, 2, 3, and 4, and put it on the table to understand what is the clinical impact. So if there is any kind of substitution on R1 and R2, it basically enhances your potency and selectivity. Okay, so do we need that to happen, or we don't need that to happen? Is it R1, R2 substitution good or bad for the drug? Good or bad? If it is good, why? If it is bad, why? Now it's your turn to tell me the answer. Okay, go ahead. It enhances potency and selectivity. So if you don't have that substitution, you basically are making a drug which is less potent. What it means, less potent means you have to take tablets like metformin, 1000 milligrams, to get a minuscule effect of the drug. More potent basically means that even a small milligram of alprazolam or midazolam can produce an effect. So you need less amount of drug to get the effect. That's what is potency. Selectivity. Why do we care? Receptors, because we know that M receptors are all over the body, 1, 2, 3, and 4. Which receptors are we planning to target? Perfect. So we gotta look for M3 receptors, and that all lies with your R1 and R2 substitution. Moving forward, we have an R3 substitution as well, where we have all this information for you guys to understand what happens when we have an hydrogen on an R3 versus a hydroxy group versus a hydroxymethyl group. For the most part, hydroxy, water solubility. That is something which should be very inherent for you by now. Anytime you see an OH group, basically it associated with water solubility. Anytime you see a methyl group, CH3, you basically confer more of a lipophilic behavior. It's because of the CH3 group is what causes lipophilicity. And what is lipophilicity? Ability to cross the membranes easily, because most of the membranes in the body are more lipophilic in nature. All right, so that's your R3 substitute. It basically adjusts the solubility and receptor interaction. We have an X substituent, which is basically not critical, but can enhance potency. It's good to be there. And then we have your N substituent. This is a very, very important. Listen to this carefully. We have N substitution. N substitution can be a tertiary amine or a quaternary amine. Right off the bat, whenever you have a tertiary amine, it is crossing a blood-brain barrier. That is something for you to know it, whether it is for this drug or any drug. Any tertiary amines has an ability to cross the blood-brain barrier. And again, we didn't get to the CNS model, but you understand what is blood-brain barrier. It is the barrier which is preventing anything which is foreign to cross the brain. Okay, if anything can cross the brain, what happens? It can go and influence the brain functioning, which we don't really want. So tertiary amines have a potential to get to the brain-brain barrier and can influence your receptors in the brain, which are M1 receptors. And what is M1 really doing? Cognitive function. Remember, if you go and block the M1, what was happening? What was the arrow? It impairs your cognitive function, delirium, person is confused or irritable because of this drug. So we don't want our drug to have a tertiary amine. We want it to have a quaternary amine substitution. Quaternary amines doesn't cross blood-brain barrier. Are we clear? Okay. All right. This is a redundant slide, but I felt a very much need of this slide so that we are all on the same page when we're talking about receptors and drugs. I got this M3, beta 3, and alpha 1. Okay, we know M3 are responsible. I mean, it's located on the bladder detrusor muscle. We have beta 3 as well on bladder detrusor, but they have opposite functions. One contracts, the other one relaxes. Are we clear? Alpha 1, it's a urethral smooth muscle. It's important for contraction so that the sphincter is closed. If at all, I have to use drugs which is interfering with this, I will use a drug which is an M3 antagonist to oppose the contractions, or beta 3 agonist or antagonist. What do we want to, how do we want to help the patient with UI if his beta 3 receptors are basically responsible for relaxation? So we want to use an agonist for him or an antagonist. If we use an antagonist, what will expect it? They're going to remove the relaxation. So if you remove the relaxation, what is happening to the bladder? Contracting. We want to contract the bladder or we want to relax the bladder? We want to relax the bladder because we are dealing with a UI problem where he is having incontinence. So we use beta 3 agonist. If you want to write down beta 3 agonist, M3 antagonist, and what about alpha 1? We want to use an agonist or an antagonist for him. Contraction to maintain continence. We want to use an alpha agonist. All right, so here's the picture for the whole thing. We have your M3 receptors on the left, we have your beta 3 receptors on your right. M3 contracts, beta 3 relaxes, everyone is harmony. For some reason, there is an underlying problem for the patient that influences his ability to contract. M3 versus beta 3, that balance is getting disrupted. That can lead to urinary incontinence. So the ideal way to help the patient is blocking muscarinic receptors. That would help to take away the M3 mediated bladder contraction. So here we have your receptor selectivity and the order. I'm not in favor for you to memorize any of this, but just understand, like, if at all I have to, if I'm basically working in a pharmacy and I have all these drugs, what is that 1 or 2 drugs I should still remember? Okay, and why do I think one is better than the other? So let's just dissect this table slowly and steadily. So the first things I told you, tertiary amine versus quaternary amine. What is good, what is bad? Tertiary is good, it's bad because it crosses blood-brain barrier. So right off the bat, I wouldn't, if at all I have all these drugs available on the pharmacy shelf, I wouldn't go to dariphenacin because it has a tertiary amine, because it can cause off-target side effects. So what we are left with is some other drugs. We have small lipophilic tertiary amine, again, tertiary amine, that will not be the go-to drug. Solifenacin, it's a tertiary amine, but it has more M3 versus M2 selectivity. I will put a pin on that, okay? Because we don't have any drug which is just not tertiary amine. I think trospium is one of them, but it is non-selective. So you understand, like you're getting one, but you're not getting like M1 versus M3. In a perfect world, if you have to synthesize a drug, you're looking at M3 selective, non-tertiary amine, and all of those things, which can probably not happen. So you gotta just take balance the benefit versus risk, and then do the call for that particular patient. Are we understanding how we have to work this? Okay. You will have one question in your knowledge check from this. And I probably have intentionally used solifenacin as an example, because solifenacin is probably one of the drugs which has the highest selectivity for M3. That is what we really need. It's a tertiary amine, but it's more selective for bladder. So that's one of the reasons we basically think of using it. Okay. Mirabegron. This is available as a prescription drug. You may have seen it in the pharmacy shelves. It's also called as Mirbitric. It's the brand name, and the mechanism is it is beta-3 agonist or antagonist. I didn't put the name there. It's an agonist. Is everyone on the same page? I'm still figuring out why are we using an agonist versus antagonist here. Why do we need an agonist? To relax the bladder. Simple. Because the bladder probably is contracting inappropriately, so we want to relax the bladder so the urine doesn't just let itself out without you voluntarily allowing it to happen. So we are relaxing your smooth muscles, so it will increase your bladder capacity. That may suppress excitability of the muscarinic bladder. So we have a structure. I don't have any SCR for this, but that's how it is. Knowledge check. Which receptor is primarily targeted by antimuscarinic drugs in treating urge urinary incontinence? Which receptor is primarily targeted by antimuscarinic drugs? So the answer is in the question itself. Antimuscarinic drugs act on which receptors? M3 receptor. What is the main pharmacological action of mirabegron? All right. Activate B3 adrenergic receptors. Which characteristic of antimuscarinic drug is associated with increased risk of delirium? Ability to cross the blood-brain barrier. Which structural feature of antimuscarinic drugs improves the bladder selectivity while minimizing systemic side effects? Quaternary amine group at the end substitute. Are we all good?
Okay, we'll take a 10-minute break, come back at 3:30. I'm sure I use the same ones as well. So, Jasmine, did you ever look at them? Jasmine was here, and she was a geriatric specialist. And her and Jim used to do, she was out pregnant, the fall from but she used to report it, and then Jim was also reporting, and he did lasers. But I don't know how to get rid of the lasers. So which is we're doing. And in the summer, I was like the.
See?
Yeah. It's because they did it virtually. This used to be not last year, but the year before that. They did this virtually. But actually, Gemini. Have some more yet. I don't know. Did they took their? Yeah. So what are we doing next week? What this extra week? You yeah, I think it's only this year though. That's year. It's fine. Let's see, from 4 to 5, so they have to pass 5 station. So that's how we didn't talk about the mediation. We wanted them to find out if they failed on day 3 and retake it. It's the only thing that we wanted to, I guess, remediate that quickly. Right, our concern is like, we can't move, like if you fail at 8, if you feel like you on day past 5 at 8, you're not gonna they only have this much. They go home, how do they come in? That's when they come back. And I guess like cancel. So we haven't. You weren't, that's what what happened, because you weren't, that was the last time. Because it was just me, College huge. Actually wasn't there because she was out. It was me, College huge. Alicia, Jack. You haven't been invited to me? I thought you said a teaching moment. I would have. She's a chick, so maybe tomorrow, if she said, ask her, because have you gotten, because she's been on all the meetings for the rest of the year. If you don't have meetings on your calendar, yeah. I don't think so. Yeah. I just, you saw her from me though. So yeah, ask her. Here we go. So she might see this next day. I forgot to add you. But I've learned. It's big. It's like the one that I have to watch. That's what Shannon's. Yeah, I think. Yes, yes. Like on the travel where you have to pay for the I don't know. Like, so she doesn't have yeah, that's what I got. Exactly. You know what I? Yeah. Agradecida con ustedes por invitación. Yeah. The thing is, so we have to do poem for this semester, and then we have to talk about, because I don't, you know that they expanded poem. Now it's poem, now it's plus stern, And so we have to plan that, but then we also have to plan the new one, because we'll teach them twice. We'll teach in the spring, and then these P1s are gonna have it in the fall. So we'll teach the P2s in the spring and then have to double teach it again in the fall. But it'll be different, it'll be home only for the P2s, but it'll be home plus derm and high. The derm and high portion, actually, the action's gonna do all of that. And then, I think I should do all of that, and then I think it's glaucoma, which I do not self-care, but that's out of self-care, so I'll do that there. Cause we kept sunburn in OPC. And we kept that. I really think it's just good to. Yeah, Richie did not. They have no science for that. Because all the stuff that had heavy science, they moved to actually infancy.
That is Richard.
All right, so let's go ahead and get started again. If the computer. There we go. So when we think of goals of therapy for treating our patients, we first want to restore continence. So we want to bring them back to a place where they have more control over their bladder, control over their voiding. Then we want to have a reduction in the number of urinary incontinent episodes. So if we can't get them back to full continence, we want to reduce the amount of accidents that the patients have. Because having accidents, it has effect on the patient's emotional, mental, can be embarrassing. Depending on their environment, they may not be in a place where they can clean themselves up. We also want to prevent complications, so pressure ulcers, nursing home placements, things like that. And then we want to improve the overall quality of life. So we want the patient to go back to a state of where they feel in control of their bladder. So when we think about non-pharm management, first thing that we want to do is we want to eliminate smoking, because smoking allows for vaso what? Dilation or constriction when patients smoke. Constriction. So if there's vasoconstriction when patients are smoking, that's also going to lead to constriction where? In the bladder. So we want to have them stop smoking, we want to start smoking cessation. We want as many things gone as possible that's going to increase the urinary incontinence. Also, weight reduction can help with stress incontinence, because sometimes there's more weight that's pressing on that bladder that's basically putting them in a position where they're going to the restroom or causing them to be incontinent. And then caffeine and alcohol reduction. So reducing alcohol and caffeine because they act as diuretics. So we want to reduce those. You also want to have scheduled regimens, so time voiding, so prompted voiding, bladder training. So basically telling patients, all right, we're going to put you on a schedule, or like we're going to develop a schedule where you basically have times to void. Your body likes being on a schedule. Your body likes a routine, a regimen. So if we put patients on a schedule when it comes to their voiding, that the body will respond to that and try to basically adhere to that. So sometimes it's retraining. Also, pelvic floor muscle rehabilitation. So Kegel exercises, biofeedback, vaginal weight training, We want to basically have our patients strengthen that muscle. It is a muscle, so it can be worked, it can be strengthened. So we'll have them do Kegel exercises. And then other forms of non-pharmacological management include either electrical stimulation, alternative medication, so acupuncture, and physical therapy. For stress urinary incontinence, when we have pharmacological management, we're gonna first think about topical estrogen. So estrogen might result in basically enhancing the proliferation of the urethral epithelium, local circulation. We want to do topical estrogen because systemic estrogens can potentially worsen the outcomes. So estrogen creams, tablets, or ring are shown to have similar efficacy. Best justified when it is with your urethritis or vaginitis. So if you have basically a alternative diagnosis of vaginitis or urethritis, the estrogen can help there. It's not an approved FDA indication, but it has worked in some patients. Another medication we can do for stress only is duloxetine. What it's gonna do is just gonna increase the urethral and external urethral sphincter muscle tone during that storage phase. So it's basically gonna strengthen the urethra during the time when the urine is filling the bladder. And that urethral strength is going to keep it closed. You can do 20 milligrams twice daily to 40 milligrams twice daily. Alternative effects are gonna be headache, nausea, insomnia. Also not an approved indication of stress incontinence, but it has shown some results. Go ahead. No. Y'all got to know me by now. This year too, I started with y'all. I don't touch y'all on doses. I don't touch y'all on doses because I don't know the doses. Now, if it was that, I don't teach diabetes. If it was diabetes, y'all have to know doses because I know those doses, but that's Dr. Folks. So when we think about anti-muscarinic agent for urge incontinence, we want to have we know that it's going to have modest improvements in urgency, frequency, and incontinence episodes. So we want to have some modest improvement of it, right? So we're not guaranteeing the patient you will never have another accident again. That's a good way to get somebody to come back to your clinic mad and upset. We want to say that we want modest improvement and we want to see some improvement over time. Less than 1/3 of these patients continue these agents long term. So it's good to say that, hey, we're going to start this, but we're also going to have you do Kegels. We're also going to have you do time voiding because we don't want this to be a consistent thing due to the side effects. You also want to talk about a benefit versus risk of therapy and see, like, do you need medication therapy for long term, or do we need to do this with non-pharm and then taper this back down? Things you want to consider is that even though majority of your population that deals with urinary incontinence is geriatric patients, you want to make sure that you are careful because they have increased sensitivity to those anticholinergic side effects. So your patients that you start on these meds are going to feel the side effects. A lot of them, as Dr. Muhammad said, they cross the blood-brain barrier, and so you have psychiatric effects that you want to be aware of. So you want to make sure that even though you're starting a medication, you're starting the medication that has the least chance of having those side effects, and also you're constantly checking in on them. Whether that's seeing them frequently, whether that's calls, whether that's involving other partners, patient advocates involved to make sure that they don't have these. Also, they have different formulations. So you want to think about, is your patient NPO? Do they prefer a different formulation? And then contraindications to our agents for urge urinary incontinence are going to be urinary retention or gastric retention. So if they have any sort of blockage there, you want to not give these drugs because you're just going to enhance the blockage. Also, uncontrolled narrow angle glaucoma. So when we look at these, you have all of your antimuscarinics for urge incontinence. I want to focus on this box where you have oxybutynin. Oxybutynin has the most different formulations, but also oxybutynin is associated with some of the worst side effect profiles. Patients are guaranteed to have dry mouth. They're guaranteed to have constipation, especially when you give them the oral formulation. And when we look at the cognition piece, oxybutynin is crossing the blood-brain barrier every single time and causing those delirious side effects. So oxybutynin, even though it has all the different formulations, it's not our first line. It's not our first go-to. We can do it, especially in patients that may not be able to take oral meds. They do have the patch and the gel, but we definitely don't want to give it to them The immediate release has more of the dry mouth, but the extended release is gonna keep those side effects going a long time. Solifenacin, and it's interesting that Dr. Muhammad focused on that. So solifenacin is the one that I prescribe the most. Because it only has constipation, dry mouth, not a whole lot of cognition issues. Derifenacin, depending on the patient, it can cause more constipation. But solifenacin and derifenacin are the ones that we kind of prescribe the most, or that I prescribe the most, because with solifenacin, I don't have to worry about cognition issues. And then I can kind of work with the patient to work through the dry mouth and the constipation. So preferred agents are going to be solifenacin, derifenacin. Oxybutynin is not what we want to use. Why do you think sometimes patients end up on oxybutynin versus the other agents?
Cheap.
Cheap. Always. The money runs everything. Money runs this country, unfortunately. So it's very cheap. It's been out the longest. Obviously, the oldest thing is the one that kind of has the most side effects because it was their first stab at it. They've refined and made other formulations. So oxybutynin is cheap, but oftentimes I tell patients, even though oxybutynin is cheap, the cost you pay for being on it is expensive. So just spend a little bit more money on the drug and have a little bit of a better quality of life. Go ahead, Chica.
Yes, no, I was just wondering, as far as it causes so many side effects and they are still prescribing it, can a patient, like, if the insurance is not, since if the insurance doesn't want to pay for it, okay, can I pay for it out of,
Pocket?
yeah,
Yeah, so you can have, so like if, let's say you're like, the insurance only covers oxybutynin, I don't like oxybutynin, just send me a script for solifenacin, I'll figure it out. You can, there's other methods, so your prescription coupon cards, GoodRx, Single Care, or you just pay for it outright cash. The thing is that for your older patients, there's already so many costs medically that $20 here and there starts to add up, $15 here and there starts to add up. So it ends up being a thing of, okay, $15 over here when I'm on a fixed income, Social Security for groceries, everything else. So for groceries, my mortgage, my car, and everything, I only have Social Security and my retirement. Am I really want to shell out extra money for a medication, or am I just gonna roll with the punches? Because I gotta do this, and that. I got 6 grandkids. Everybody wanted $100 gift card. I don't got $600 for them. I gotta figure that out. All those things kind of come to play, and that's what patients tell me. Is that it's not that, oh, I can't pay $25 for this drug. Like if it was just the drug that I was worrying about, but $25 versus $4 in retrospect to my whole life that I have going on a fixed income, I'm gonna go with the $4 one. That's covered by the insurance. And you'll just deal with the others as they may. So that's how patients end up in that situation. Wanted to let you guys know that anticholinergics are on the Beers criteria. So even though these are our go-to drugs for urinary incontinence, they are on the Beers criteria. What does this mean? This does not mean that you don't prescribe them ever. Because if you never prescribe things that were on the Beers criteria, a lot of patients wouldn't get the help that they needed. But it's something to know, to counsel on, okay, this can have risk of dizziness, falls, delirium, and those sorts of things. So even though they're on the Beers criteria, and I know that you guys are probably taught next semester, avoid medications that's on the Beers criteria. So in my long care group already knows, we've talked about Beers criteria, but I do want you to know that like, just because they're on the Beers criteria, you don't leave the patient hanging with no help and say, well, you're 67, it's on Beers, I don't know what you're gonna do, girl, you gotta go buy the diapers. No, don't say that. Literally, you just tell them that you have an increased risk of cognitive decline. So make sure, who do you talk to every day? Like, do you talk to your son every day? Do you talk to your daughter every day? Do you talk to your best friend every day? If they start to notice any change in your behaviors, let me know, those sorts of things. When we think about our beta-3 agonists, we've got mirabegron and vibegron. For the mirabegron or the Myrbetriq, it's 25 to 50 milligrams a day. It requires a renal dose adjustment. It should not be crushed. So if you have a patient that's NPO that can't swallow pills, it's not for them. Its efficacy is similar to the antimuscarinics. The thing is it does not have any anticholinergic side effects. So patients that are really having a hard time with the other drugs, they can be on Myrbetriq. You don't want it to use it in patients that have severe uncontrolled hypertension because it can raise the blood pressure. Thinking about the beta receptor, if you stimulate the beta receptor, you increase blood pressure. So you want to make sure that patients that have uncontrolled high blood pressure either control the blood pressure and then get it on there, or just go to the antimuscarinics. Often could cause nasopharyngitis, UTI, headache, constipation, and dizziness. It has drug interactions with CYP2D6 inhibitors. Virabicron is 75 milligrams daily. It's not recommended in patients that have end-stage renal disease. It can be crushed. Similar, it does not have any anticholinergic effects and does not have any warnings for hypertension. Side effects include headache, urinary tract infection, nasopharyngitis, can also have some GI, so nausea, diarrhea, and upper respiratory tract infections. It does not go through CYP2D6. These drugs are expensive, so sometimes patients will be on the other ones, but they work very well. Patients that do get on Myrbetriq, I don't hear any more complaints. So I took Myrbetriq and everything was great. So they work, and they really do their job well. When they came out, we thought this was going to be like the ultimate answer, but they won't come down on the price of them. So we still prescribe the other drugs. For overflow incontinence, we think about the pharmacotherapy that we'll discuss later tomorrow. So your alpha-1 blockers, your 5-alpha reductase inhibitors, which you guys know very well, and your phosphodiesterase inhibitors. And so just some key points of urinary incontinence. You want to be able to identify the type of incontinence that they're experiencing. So going back to, I'm gonna go all the way back. So thinking about the types of incontinence, if it's stress incontinence, they're gonna say, hey, it's stress, so it's incontinence upon exertion. So they're gonna say, when I sneeze, I end up having an accident. When I laugh, I end up having an accident. It's gonna be upon exertion. I went to pick something up in my job and ended up having an accident. I moved a different way, or I had to run, or did something and ended up having an accident. That's stress. Urge, they're gonna be like, I always have to go to the bathroom. I feel like I have to go to the bathroom, nothing comes out. Then I feel like I have to go to the bathroom, nothing comes out. Then all of a sudden I end up having an accident. They always have to go. For overflow, is gonna be like, I never have to go to the bathroom, and then when I do, I don't have any time. I just end up soiling myself. And then I don't have to go anymore because it's basically overflow. So they don't have the feeling to go to the bathroom at all. The bladder fills up, it gets too full, and then it just expels. So knowing what type of incontinence the patient is experiencing is, and basically based off of, I'm all open tomorrow. Basically based off of what they say and how they're feeling is going to determine the pharmacotherapy. First line for urge is non-pharm. Second line, you want to do your antimuscarinics and then your beta-3 agonist. Which antimuscarinics are we going to use? Which one? Starts with an S. Solifenacin. So if you see solifenacin, pick solifenacin. Y'all love to giggle when I say these things, and then when it's time to go over the exam, I be giggling because I'm like, I thought I said it. So let's make sure we laugh together, and we all get it right. You want to consider the impact of anticholinergic adverse effects. The beta-3 agonists don't have anticholinergic properties, but they may be limited by cost, and we can't use Myrbetriq in patients that have uncontrolled what? Hypertension. This is recorded, so remember the call and response questions I asked you. You can go back and listen to it. Stress incontinence has limited pharmacologic options. Non-pharm you want to emphasize, but you can also use duloxetine and topical estrogens. And the overflow incontinence is often caused by BPH or other things, so you want to treat that. And then after that, determine what is going on. What questions do you guys have?
Can you please explain more on the mixed incontinence?
The mixed incontinence is basically a combination of stress and urge. So it's like, for mixed incontinence, it's like a patient, they feel like they have to go to the bathroom. And they always have that feeling of urge because they basically have that overactive bladder. But then also it's stress because if they do something, they end up also having to go. So it's really kind of a combination of both. You've got that incontinence upon exertion where they do something, laugh, sneeze, cough, carry something, trip, fall, and they have accidents, but then also they feel like they always have to go and have the overactive bladder. Sometimes with the mixture of it, we kind of treat them, or how I see them is if a patient has a mixture of stress and urge, I just treat for the urge, because sometimes they always have the urge, but they never have to go, and then when they do something, they end up having to go, but if they didn't have the urge and weren't always running to try to relieve themselves and relieve their bladder, they wouldn't also have like the stress portion. It's really difficult if they have mixed. I kind of just go about it, treating it if it's urge, and then seeing after that what happens. Most of the time it is kind of an urge situation, and once you get something on board and then you start to tell them to do like the pelvic floor muscles training and get that time voiding in, patients start to feel a bit better. Also telling them to regulate their like schedules. So like patients that have urinary incontinence, if they're drinking anything at night, they need to stop. So I'll tell them nothing to drink within 2 hours of going to bed. Like 2 hours, I'm like, yes, 2 hours. Because you're older, so your digestive tract moves slower, so whether it used to be 30 minutes, it's now 2 hours. So that I've seen success with that, but it just depends. What other question? Yes.
So based on symptoms, okay. Is there a certain number of times that the patient has to warn for you to then classify it as urinary incontinence?
No, so basically, there is not a certain number, or like there's not a very like diagnostic criteria where they have to have X amount of accidents or have X amount of voiding. If they basically tell you that, hey, based off of my usual schedule is I urinate 2 to 3 times a day, or I urinate once in the morning, once in the evening, and I'm now either not urinating then, or I am having accidents, even though I'm getting ready to go, or I'm always feeling like I have to go, then that basically kind of cues you into the urinary incontinence. You want to ask about the other things, so the other etiology, that slide that we had, you want to look into those things to see if those are the issues. But if you don't see any of that, that's kind of your clue to being urinary incontinence. So, but no, it's not as hardcore as our other things that we diagnose, where it's like 2 levels of these or 2 incidents of these. It's really very much symptom based and based on the patient. And I will say, when you start talking about medication therapy, that's how you can tell if it's really urinary incontinence. Because when you say, oh, we can give you a medication for it, they're like, oh no, it's not that serious. Okay, then it's not urinary incontinence. Or if how many accidents have you had? I've never had an accident. Okay, it might not be urinary incontinence. It might be more of a scheduling thing or a non-farm thing. But when it is urinary incontinence, they want something because they're tired of the symptoms.
So if I take the medication, how would I know that my urine incontinence is what you call improving? There's no certain number of urine that I can just say that, okay, I used to have 8, and now having 3, so there's improvement. How would the patient gauge the efficacy of those kind of medication?
So they would look at how much they're urinating once they start the medication versus then how many what we call lower urinary tract symptoms are they having. So how much of the urge to go, cramping, pain, accidents they're having. So like if they're like, okay, I don't make it to the restroom probably 2 times a week, I have an accident. And then now I see them in 2 weeks, they're like, oh, I haven't had any accidents. That's an improvement. If they are saying that, hey, like I used to pee a little bit or like urinate a little bit when I used to cough or sneeze, and now that doesn't happen, or when I used to laugh and now that doesn't happen, that's improvement upon the symptoms. So it's really symptom-based treatment and symptom-based kind of diagnosis. If you don't have any other underlying etiology, then it is that. And sometimes you do have the underlying etiology, but you're still treating it. So there are patients that do have dementia, and so they have dementia, but they also have urinary incontinence. And so while we're working on the dementia, we're also treating them for urinary incontinence. What other question do we have? Seeing none, I will see you guys tomorrow.
Thank you.
Mm.